right, well, we're back for another episode of Wellness Warriors with Terrence, our non-surgical orthopedic specialist, which we're going to learn a lot more about today, and then Shelby, myself, working over in more of the functional medicine world. So welcome back.
Yeah, welcome. It's going to be an exciting day. We get to finally talk about the biotensegrity model. I know that Shelby is super excited.
I didn't Google it.
Right.
I didn't. I've been waiting weeks to find out about this.
Find out what this little object is, what it means and what it's for. So, and that could be, a great kind of, not segue, but a great way to start.
Yeah, can we talk about this first? Because I really want to know about this.
You're really excited about this little thing. Okay, so biotensegrity. So it's kind of a different way of looking at how the body kind of is related to itself versus kind of true biomechanics, which we think about biomechanics and how the body is moving together, and this is a little bit more of thinking about it like a robot or a machine, and more of a body and what a body can do. So kind of one of the things you think about, so we have bones, so that's kind of what the wood components in here are kind of depicting our bones and structures. But if we think about our body in terms of bones and kind of a framework of bones, if we were to just put those up, like they're not going to stand up, they're not going to move, they're not going to be able to do things in space and manipulate them the way that we want, and everything is interrelated with that. So say you have like a plastic figurine, like you stand that thing up, like it's kind of stacked up on a framework, but you have to have it perfectly aligned so it stands up, so it doesn't fall. If the feet are just a little unbalanced, all of a sudden it tips over. So this is a model kind of showing how we have a combination of compression and tension forces holding everything together. So these guys, like this one, doesn't have anything supporting it, nothing holding it up, like a framework holding it up, but it's supported by the tension. So now what happens when we think about a body, this thing can move, and we can move different parts of it. So I touch it here and pull a lever here, but we're actually moving over there as well.
Oh, sure.
So now the idea is, and this is where it kind of comes into my world of what's happening and what's causing breakdown. So I might be moving something over here, but something over there is now moving too. So this is like all of us think about compensation. My knee hurts on the left, so I think that might be why my back hurts. Like every time someone says, I think that's why, it's like, that's probably why. At least it's a part of why. It's usually not like 100% like you have this knee injury, so that is going to cause your back to hurt, or that is going to cause your shoulder to hurt, or something like that. But if we look at it and we know that we push here and it moves over to the other side, or we pull over here and it moves that whole structure. So everything is impacted by one piece moving. So again, you think about a shoulder moving through space, and we have all of these different tensions and movements all working together to try to make it happen. And that is changing your balance, both from your low back to your stance. We think about it when we're like, how do you throw a ball? You lean back, you throw into it, and you get your whole body into it to get more power through it. So it all makes sense, but we just don't really think about it this way. So now when I see someone in kind of the non-orthopedic or non-orthopedic, non-surgical orthopedic world or orthopedic world, we think, what is going on? And a lot of times someone comes in, it's like, my shoulder hurts. It's like, well, so we're going to focus on what might be going on in the shoulder and what might be breaking down there to cause your symptoms, but what else is going on in the rest of the network? So if something, again, shoulder is hurting up here, what's going on in the low back? A lot of times I'll show people a picture of the low back and how we have, or the back in general, and we have this fibrous network that connects everything. So it's kind of like an exoskeleton around everything too. So now, again, that little tissue is pulled over here, and that's going to affect the whole body. So instead of just focusing on the shoulder, we can focus on other parts of the body to get that to feel better as well.
So in the orthopedic world, you're not just looking at, single joint, someone comes in, my shoulder hurts. You're really looking at what else is going on that you need to address.
Exactly. And it's a difficult way to pull it around, because of course the shoulder is the thing that brought you in, so that's what I want to make feel better. That's what I want you to leave here saying, my shoulder was better after doing that. And that's where the idea of just going into orthopedics and fixing that and then going on, we're going to continue to break down and have other problems again. And that's why I tell so many of my patients that we can't just fix this, and almost nothing that you do in the medical world do you fix. Most often you're manipulating, you're managing, and you're figuring out ways to manage it in the future. And that's where so many of my patients, it's like, so physical therapy is probably one of the number one things that they can do, because they can take that with them forever. Like, I can do things with a needle, and I can make tissue calm down, and I can make you feel better immediately, or relatively immediately, with injections that I do, but I can't you're not going to have them in your back pocket every day when you have this breakdown. So if we're learning things, and that's kind of a great kind of segue into one of the first steps of non-surgical orthopedics is physical therapy.
Okay.
Is that you will be learning how to move, kind of learning how all of this impacts itself. So, and again, so knees are probably one of the most common things that we see, and so they come in with a knee pain or a knee problem, and one of the first things we recommend is doing physical therapy. A lot of places, they probably either haven't done physical therapy before, or there's certain treatments that we do that need physical therapy for the insurance company to cover further treatments. And so they'll have gone to a physical therapist, and the physical therapist says, well, I know what you need. You just need to do these, you need to do this for 4 weeks, and here's your set of exercises, and then you can go ahead and get that other treatment.
Sure.
Many times that'll fail because we're not treating the problem. I'm giving you something to make it feel a little bit better, but you learning how to do the physical therapy pieces and learning how what you're doing around the knees is actually affecting what's going on in the rest of the body is going to be a huge benefit to you. The other thing I tell people about physical therapy is that we've gotten to this point. We're broken down. Most of the time it's not an injury. I mean, there's a lot of injuries that have happened at some point in the road, but there's something that you do or have done and probably continue to do chronically that is actually breaking you down. Like we think about this model, and something is a little bit off. And if you're not aware of that, and most of us aren't, like our body just starts to make these little adjustments. I mean, numerous times have I seen people come back from physical therapy and they're like, oh yeah, they pointed out that this isn't working quite right. It's like, well, yeah. Like, and that's why you're breaking down. So it's not just physical activity that a physical therapist has you do. They're breaking down your physical movements to make sure that we can help support what was broken down and help you maintain it in the long run. And again, and most of us will stop doing our physical therapy once our pain goes away. Because it's like, well, I don't have pain. And one of it is we don't have that reminder. We don't have the thing that we think about. So we don't have the pain to say you need to do your therapy. You had someone tell you that you should do it for a while, but that always lapses. And that's another good reason to have someone go to a physical therapist compared to just do some physical therapy exercises that we've shown on a piece of paper, because you have that extrinsic motivation. Someone is going to, you have someone that you're going to check in with and say, did you do your exercises? Are you doing them or not? And most of us, like, we don't want to lie, most people, and we want to make other people happy. And not that it only makes us happy to hear that you're doing your exercises, but we want you to be better, and that's the best way to make you better, is to teach you how to move better so you are breaking down less in the future.
I think that's such an important point, because I see, and I don't know, a lot of patients, I'll say, oh, have you done any PT? They'll bring up pain in their functional med visit. What have you done? Have you done PT? Oh, I've tried that. It didn't work. And I think sometimes the part is they forget it worked while they were doing it. And, it's probably not a lifelong, like you do this 4 weeks at PT, you're good for life, because if you're not continually doing it, you're probably going back to those bad compensatory mechanisms. But I think that's a good point. How do you address that if somebody's like, oh, I've done PT, it just doesn't work?
Yeah, part of it is I just make sure that they've understood that piece of it. And sometimes I will remind them, because there's frequently that I'll get patients coming back like, this was bothering me a couple years ago, and it was doing well. You did that injection, and like all of a sudden, like, I was better, and let's just do that again. It's like, well, like, think about everything else we were doing at that time too. Like, we didn't just give you an injection and you got better. There were all of these things that kind of led up to you feeling better. So a lot of times I will bring that up, or I'll ask if they're still doing their exercises, and I'll kind of just that same conversation that we just had about how the body moves and how we've gotten to this broken down point. And we need to make sure that we are, and some of it is just mindfulness of how we're moving. I mean, many times we forget about it. We start to hike our shoulders up to give our shoulder more range of motion. It's like, I can lift my shoulder up, and you see them raise their shoulder way up before they're actually getting their arm up, and that gives you a whole lot more motion. But it's not coming from your shoulder. It's a compensatory movement that isn't really shoulder, and now that just fatigues everything else in the network and starts breaking down. Now we're pulling here, which is starting to pull up on the neck and causing neck breakdown as well as shoulder breakdown. And all that. So, just try to talk with them and kind of say the number one I get is that I am active. Like, I am doing things. It's like, I know you're doing things, and that's, and you're broken down. And so let's figure out how that happened. And it can be even someone who's very gym savvy. I mean, even like myself, like, I know every exercise, not every exercise. I know many of the exercises I should do for different things, but I break down too. And I compensate. I move things because our bodies are just great at finding efficient movement. So if we find that efficient movement, we go to it, and then we start breaking down in other ways. But if you have someone there to catch it and tell you you're doing that, and then you think about it.
Yeah.
And the next time you're doing that exercise, now you're aware of it. So it could be as simple as climbing stairs. How is your body arranged when you're climbing stairs? What kind of accommodations can you use to get up those stairs or a ladder or something like that?
Yeah.
So just try to break it down, kind of make it make sense, and have them think about it in a new way that maybe they hadn't before.
Yeah.
And some people are still very resistant. They're like, no, and sometimes it makes them hurt more. And then that's another thing where I can usually come in, where we, and definitely at Rejuve, I don't just like send you off to PT and then we'll see you back in 6 weeks. Every now and then that happens because it's like, it's a very, like, they're not in a lot of pain. It's just something is a little broken down. They're like, I know something's not right. I want to do something to help it feel better in the future. So yeah, we will talk about that. Let's get you into PT and we'll see you back and see if it's gotten better, and then we'll go through. Some people are coming in and they have so much pain, they go to PT and they're in so much pain and they don't get any better, where we can do some injections along the way so they're feeling better while they're doing physical therapy, learning these new things, getting their body to compensate more, or not compensate, but move more efficiently in the way that it needs to, and then they can continue to do PT. So that'll be another piece that, like, if it bothered you too much to do it, let's try to back it up and make your body feel better while you're doing physical therapy, so we can see positive response in the end.
Awesome. Well, I think that's great.
Yeah.
Do you guys use braces too?
A lot.
Okay.
And even just yesterday I had a conversation with the patient. She was wondering, like, what can I do? This was knee arthritis again. Probably one of the most common things that we see is arthritis is within the knees. What can I do to slow down that arthritis? And that's, I mean, a concept that many people wonder, and they're like, I wish that there was a cure. Technically, there are cures for arthritis. It's just, it's moving right, being aware of these breakdowns, treating it before it becomes big and broken down, and trying to help us out. But again, like last week we talked about medicine 2.0 and 3.0. If we're just fixing what's broken, it's harder to keep things functioning well, where if we're maintaining it early and making sure that we're doing proper movements early, we're going to help. So get back to the orthotic question or braces. For knees, a lot of times knees will kind of break down unevenly, and I have this is my model. I use this all the time in patients. Most of the time we see one compartment breaking down. So the knee has an inside compartment and an outside compartment, as well as one underneath the kneecap. Most people are going to break down to the medial side, to the inside of the joint. So when they're walking, that side is wearing and tearing a lot more than the outside is.
Sure.
So we're kind of walking like this. Every step that we take, there's a little bit more gravity pushing on that piece. So we can put you in a brace that opens you up a little bit. So it actually cantilevers that joint, so it's less pressure on that medial component and a little bit more on the lateral component, but then it just evens it out. And it's a way of kind of delaying it or taking it back. But again, most people don't like wearing braces, so they're like, did you get that brace? Yeah. Do you wear it? Not really.
Yeah, so true.
And all of us are kind of like that. Like, we like our bodies to move free of resistance, but sometimes that resistance is also positive because it limits excessive movement. It limits our bodies kind of, and this would be like a back brace. Like, a lot of times it's like, well, I can't lift as well, or I can't bend as well. It's like, that's part of the issue. It's like, you're probably bending improperly, and now we put this brace on you to keep you in a better alignment.
Sure.
And then you're not going to break down as much, and we can actually delay that process of breakdown, give you that support when we need it. And most braces, believe it or not, don't make you weaker. And I think this depends too on how you wear it and how you're educated on wearing it. So I'd say a back brace is a big one that there's studies that'll show weakening of the core musculature if you're wearing this brace. But I never tell people to wear it all the time. This isn't something you should have on all the time. This is something you should have on when you're doing bigger activities, when you are lifting, when you're outside going for walks or gardening or yard work or housework, things like that, where you're going to be bending, stooping, lifting, where you might kind of put that spine into a vulnerable position.
Sure.
But I also tell people, don't just rely on the brace. Don't lean into the brace and just kind of let your body kind of slump into the brace. That you want to, like, when I wear it, it makes me feel more aware of my body positioning. So it's like I'm going to actually activate my core a little bit more, because you can feel that. It's a biofeedback. Like you slouch into it and you can feel that pressure on the back brace, so then you kind of lean out of it. And same thing in like this type of a knee brace isn't going to make your knee weaker. And again, we want you to be doing physical therapy exercises so you can strengthen everything else around the joint. That joint is going to be extra supported, so it's not breaking down as much. You're not having as much pain. You can do more pain-free movements. You can overall get better by using it in a smart manner. And sometimes, I mean, arthritis can be so progressive that you do need a constant brace. And sometimes it's better to have a brace on the outside than doing a major surgery, and now your kind of brace is on the inside. Kind of the same thing, less reliant on you putting it on and using it. It's always there. But sometimes the cost to get there is significantly greater than not having the surgery.
Sure.
And that kind of probably brings into kind of like the non-surgical versus surgical. Like that is the technically the big change is going towards surgery. And I mean, you talk to a lot of surgeons and they are going to recommend conservative care first. I feel many of them don't give it as much of a solid effort because what they have to rely on afterwards, they have a little bit more control with. And most humans, we like to have that control. We like to be able to do something, where if you're just relying on a patient doing conservative things on their own and they've maybe tried a cortisone injection and it maybe got better for a little bit, they can do something, they can kind of quote unquote fix it. And most often it's not necessarily a fix, they're creating a change. They're going to cut something open, there's going to be soft tissue injury, there's going to be the body learning how to compensate now for something new. And there's certain things where we need to do surgery. I mean, if you have a big giant piece of chunk in your knee, like you can't, if that's in the way of your movement, then you need to get rid of that. If it's something that's just broken down and every now and then causes you pain, or maybe even constantly causes you pain, but is not actually getting in the way of movement, or you're not completely unstable because of it, there's a lot of things that we can do to help you feel better, like the bracing, like the physical therapy, and then we'll get into some injections later on. Which also puts into perspective the thought of kind of like our non-traditional, and I'll probably even say our non-traditional non-surgical orthopedics compared to orthopedics. So
sure, that's a good point, because you guys are using a lot of people will come here, I've had a cortisone, it worked for a while, did the 2 or 3 of them,
or it didn't work at all,
and then it starts to the first one worked okay, but then now it's not working at all. So do you see a lot of those patients who are following up?
Definitely. And I think you could probably say that in both worlds, that you're going to see some of our patients that go there. I'm thinking less. I mean, most of our patients notice changes that ain't going in a positive direction. So corticosteroids, so your cortisone injection, usually the drugs we're using are not actually cortisone, but they are based on this steroidal anti-inflammatory model. That steroid anti-inflammatory is actually going to break down your joint more. So it's going to stop all of that inflammation that we talked about. And I think in last topic we talked about inflammation and how the inflammation is bad and we want to put out that inflammation, but at the same time we have good inflammation. And we want that good inflammation to happen. So we're constantly breaking down some, and we want to rebuild that. But if we have a drug in there that is stopping inflammation from happening, it can make you feel better if inflammation is the sole point of your pain, but it may not make you feel any better because it may not be just the inflammation causing the pain. It could be the structural components or the cell health within that joint. And the corticosteroid is going to cause more breakdown, and that's been studied time and time again. That's why they won't do more than usually 3 steroid injections within a year, because they know that they are causing breakdown to the joint, and eventually it isn't going to work at all because you've had that much more breakdown, and you can't overcome those tissue changes with a drug that just stops inflammation.
I think that's a good point. So you said you see a lot of knee arthritis. What are you seeing as the biggest causes? I know you said injury isn't typically that, but what do you think the biggest contributing factor is?
I think one of it, in inflammation in general, so we talked about that before. And technically, it comes with age, and there's probably a good, 30% of Americans probably have some breakdown. I want to say that it's something like 20% of those that have that breakdown are having that pain. I suppose that the numbers are probably higher of where breakdown is actually happening, and then the symptomatic, I think, is around like 20% or so of those that have arthritis that are having the actual pain because of it. And this comes from a lot of the things we talked about last week. It can be other inflammatory factors. What else is going on in your body that's causing inflammation? One of the reasons we send people to you very often is to find out their hormonal balance and what is going on inflammatory within their body, that if we can help calm that down, that their arthritis pain is going to be significantly less. And I don't know if there is a one kind of pure cause out there, because you can look at 2 people going through the same life, and one will have a lot of breakdown arthritis and the next one may not. And it could be from compensatory movements, it could be from little injuries in the past, it could be from little habits, like you might lean to one side more than the other side. So I don't think that there would be one thing that you could really look at and say that this is the cause or the number one cause. One great cause for knee arthritis is knee surgery, and that would usually come from someone who's had some type of an injury, but it doesn't even have to be an injury, it can be chronic breakdown. And if they do like a meniscus repair or even a pulling out of meniscus, that will lead to arthritis. Like that is almost a guarantee. If you've had a knee meniscus surgery, you probably will have arthritis on that side, and very commonly we'll see that. You look at x-rays and it's like, well, something happened here. Like, oh yeah, that's the side I had my meniscus removed, and you can just see that side is just completely collapsed. And then again, we'll try to work with the remaining tissue to try to help it.
So say someone tears a meniscus and it's a minor tear. Is there anything that non-surgical orthopedics can do to help that, or is it like, nope, you tear your meniscus, surgery, that's it?
Right. And this is probably the coolest thing that we do in our kind of non-traditional, non-surgical orthopedic world is PRP, platelet-rich plasma. You can do stem cells, and that too depends on is both kind of budget as well as kind of what you're looking to repair. Usually that's going to be more severe arthritis compared to like a meniscus tear. So one of the reasons, if you talk to a typical orthopedist, they're going to say that meniscus isn't going to heal, or is going to heal very poorly, because it doesn't have a good blood supply. Our body needs blood to be able to heal because it brings in these platelets, and the platelets are the things that we can then extract from your blood, concentrate. So they're minimally processed. So we're just putting them in a centrifuge just to spin them down, and then we pull out this high concentration of platelets, inject that to the tissues around the joint as well as inside the joint, as well as these little, so we're talking specifically knee, the little ligaments that help hold that meniscus in place. So when we're doing this all ultrasound guided, so you can see all of these structures under the ultrasound, and we're injecting those specific locations, putting these healing products in there, so then the body can actually recycle its ability to heal that, where otherwise if the blood isn't coming there to send those signals, it's not going to heal. So meniscus tears, even moderate to severe meniscus tears, as long as there's not a lot of instability going on, those are repairable using PRP, and we can that's been proven time and time again on imaging studies. So you look at an MRI, even like an ACL, that's one of those where people are like, you tear an ACL, like you need surgery. I think if it's a complete ACL tear and everything is gone, you probably do. But if you're you are not going to do surgery, or maybe you're kind of at that point in life where it's like, how much do I really need this ACL? It's still holding me a little bit. That can actually regrow under an MRI. You can look at an MRI before and after, and you can see growth of that ACL tissue coming back together to help support the knee.
And that's with the PRP and stem cells?
That's usually just PRP. I'd say most studies show more PRP than the stem cells when they're looking at those, because I think it's a little bit more accessible and a little bit more usual. And usual in the terms of predictable. They're going to do the same type of thing, although that can be different too. So we look at PRP, and we look at the amount of platelets that you're putting back into the body, and there's certain levels that they've looked at, and the higher the level of platelets that you inject back in, the more likely you're going to have healing. So if you go somewhere where they have a system that doesn't have as high of a platelet count, you're probably not going to see as good of results as somewhere else. Also, if they're just injecting that platelet into your joint itself, you're probably not going to see the results. Or a much, maybe only like 30%. But if you're injecting kind of all around the joint, so you're kind of encompassing, so the biotensegrity model, it's not just the joint, it's not just right here in the knee that things are broken down, it's all of that stuff around the knee that's actually causing that breakdown as well. So now if we're supporting the outside of the knee, hitting the retinaculum, which is kind of like the joint capsular bag around it, the pieces that hold the kneecap in place, the ligaments that hold the knee in place, the things that hold the meniscus in place. We're supporting all of these things all together, and we can actually have a healthier joint in the end that can repair things like that ACL. And it takes a good return to activity protocol. If we just inject those in there and you go right back to everything that you were doing, probably not going to work super well. We need to give it a little bit of time to start laying down a good foundation. I always tell people a big cut in the skin is probably one of the best analogies that we can actually see. You cut your skin. I'm thinking like, this is a big cut. Like I was going to go to the ER because it was pretty bad, but I was like, I didn't feel like waiting. So I'm going to cover it, and we're going to let it heal. You're going to put a bandage on there, and that thing is going to be, you are going to protect it. Like, a good solid week, like you're not going to touch this thing. You're going to ease that Band-Aid off, and you're going to kind of clean around it, and you're going to like treat it really nicely. And that's usually about a week. And this is kind of funny if you watch the next injury that you have. You just kind of watch how you kind of baby it and think about it, and how for the first week you're very conscious about what's going on there. The next week, and this I like to think about it on your hands or around something that you're using a lot. So now, say you had that big cut on the top of your hand, you're not going to reach into things that are likely going to brush against it.
Probably not. Not more than once.
Right. Yeah, it might happen like when you don't necessarily think about it, but then you're going to be more protectant of it. You're not going to be reaching in, into the car or not under the hood. Doing mechanic work, if you have this big old gash, and I suppose mechanics would be like, no, I do that all the time.
For sure, they totally do.
But we're going to protect it. We're going to think about it. We're going to try to use something else to to help that area heal. And usually, again, that's probably about a week that we're very focused on it. Kind of the next week is like, you know what, I'm better. I don't have to be as conscious about it. I'm not babying it and cleaning it all the time, but I'm still aware that it's there and there's that kind of scab over the top of it. But if you rip that scab off, it hurts. So you are still kind of like, you're conscious about it. And then after a couple weeks, kind of you get into that third week, and now you can mostly forget about it. You still know it's there. You can still feel it. If you scratch across it, it doesn't feel like normal skin, but we're getting back towards normal. Okay. And usually, probably around that 5-6 week mark afterwards, you're like, it happened. Don't really think about it unless you really need to. And that's kind of the same with the body. At that point, when we're looking at PRP, we do want you to still do things because we're going to continue to remodel for a long time. So initially, when we look at, say, a PRP is, one of the most common treatments that we do. Probably the first 2 months, we're seeing the most kind of foundation growth, kind of new. So initially, it's inflammation. Then it's going to be this kind of proliferation phase where it's putting things on top of what was already there. And then we have this maturation phase that lasts, up to 24 months after you do something like PRP. So probably the first 3 months is where you see the first kind of gain, like, oh yeah, I did that and I can tell that things are different and I'm feeling a little bit better. I have more function back. You might still have a decent amount of pain, but that's kind of okay. We can still remind ourselves that something's going on. Usually around 6 months is probably where we see people kind of plateau out as far as their pain relief, but their body's going to keep working with that tissue and keep smoothing it out and making it kind of better, more functional tissue. So this is a very long-term treatment. It's not just like you do a PRP and you feel better. Some people do. Some people you do a PRP and within a few weeks they kind of go through that little baby phase and are like, you know what, I'm feeling way better. I'm golfing. I'm running. Awesome. I have no concerns. We don't want you to run that fast after a PRP, but you're going to feel like you probably can. Okay. But we can build those things up, and it's going to be that longer-term kind of remodeling. So that was a long way of getting to the will it fix the meniscus? A lot of times it can. It can go in there and actually remodel, relay down kind of a foundational growth. The body is going to come together, fix the tissue around it so that meniscus can heal better. And we want some stress into that area too, because if we don't stress it, then we lose all of that integrity, all the signals that the body is sending, because the body needs that and needs that input to say, this is the stress that it's going to endure. So these are the things I need to do to it to make it feel better and healthier. Just like you put a cast on a wrist for a broken arm, you get that cast off, the muscle is weaker, the joints are weaker because you haven't been moving it for 6 weeks. So we want you to be doing these things so it stays strong in the area.
Awesome. Yeah. So if someone's thinking like, I don't really want to consider PRP because the downtime is probably more, it's probably not actually more downtime than if you were to go have that repaired surgically. Right. You're probably having more activity. Right.
And this is one of those where we have to like really break it down and look at it, because you go into surgery, you're probably going to be feeling better pretty quickly. Right. Because if say it was a meniscus that was causing some irritation, they go in there, they take it out, you recover from that kind of surgical wound on the outside, and your pain is less. But what does the function look like in there? If they're actually going in there to repair a meniscus, you're going to be probably non-weight bearing 3 months or more. You're probably not going to be running for at least 6 months. So if you're actually going in there and repairing things and having your body repair things, it's going to take a long time. You're going to be down for a while. And we always think about it in the grand scheme of life. It's like, do you want that quick reward? Right. For kind of feeling better right away, or are you willing to put in a little bit more time and effort to see what will happen?
Especially with that significantly increased risk of arthritis in the long term.
Right, because I'm going to feel better now and I can go play softball this summer. Yeah. It's like, so now you go play softball this summer, but now what happens in 5 years? Because it doesn't take that long. It's not like it doesn't take like 20 years and you will have arthritis. You take out that meniscus and within 2 to 3 years you are going to see X-ray breakdown of that bone. Wow. So it doesn't take long at all to see that breakdown, and you'll even talk to a lot of orthopedic surgeons that are leaning away from doing meniscus repairs or meniscus removals, I should say, because they see that breakdown. They know they're going to have more arthritis, and they will end up needing something more in the future. So that will cause you breakdown. So interesting. Do we want to do that now? Because now in 5 years you might always have an achy knee after you do things. Not able to do the things that you want. You can't get up and down off the floor like you want, or it feels crickety when you're trying to do that, compared to, I'm out of pain right now, but let's look at the long term of where you want to be in 5, 10, 15, 20, 30 years.
Okay. Oh, that's really great. Yeah. And when you guys are doing injections, whether it be PRP, stem cells, HA injections for the knee, nerve injections, you guys are doing, I heard ultrasound guided.
almost everything is guided by something, and that's kind of one of the things that will set us apart. And I think that in general non-surgical orthopedics, I think they typically do use some type of guidance, and that I shouldn't put that blanket out there, because there's a lot of prolotherapists out there. So prolotherapy is another word for these kind of non-surgical orthopedics that are working with things like, prolotherapy is just using high concentration of sugars compared to using your body product of PRP. And then stem cells, the kind of the step above that. So ultrasound guidance. If you go through the right training, you can really feel all of these things, and you know kind of almost exactly where you are. Here at Rejuve, yes, we almost always use some kind of an ultrasound guidance or x-ray guidance to be able to put that medicine where we want, not where we want. And that's something that you can definitely see a change with patients, both in comfort level, their confidence in what you're doing, as well as knowing that I'm putting the medicine where I want it to be.
Right, you're not guessing.
Right, because and you hear from enough patients around where they're like, carpal tunnel is one, where it's like, I have these carpal tunnel symptoms, and what can you do for it? Or I've had a steroid injection in there, and you talk about it, and they put a needle, and they just put medicine in that area. It's like, you know all the things that are there.
Right.
Number one, the nerve. If you hit the nerve, that causes pain. If you're outside of that carpal tunnel, it's not going to do you any good. Again, it's just stopping inflammation. It's not helping that nerve heal. So one of the things we use a lot here is something called dextrose. Dextrose is the sugar compound. I think we talked about it a little bit last week with inflammation. When we have the mitochondria not working efficiently, they kind of turn off their borders. So now they're chronically inflamed, and they're kind of shut down. We can give them this dextrose, which gives them a little bit more energy, a little bit more life, helps open up those channels so the body can heal back and forth a little bit, give that powerhouse back, as well as reducing pain and improving function. So the dextrose that we use for injection, we do that same thing into like a knee joint or into the spinal canal. If we want to do, it's like our epidurals are very low dose steroid and mostly dextrose, which has this other completely different healing property about it. So in like a carpal tunnel, we're going to see the nerve. We're going to see the median nerve. We're going to see those other tendons around there. On the imaging, you put the ultrasound over the top, and you can see all of those structures, and you kind of like put a little donut around that median nerve, so you can see it all. If I were to think about just dropping a needle in there, it's like, am I in a tendon? Am I in the nerve?
Right.
Am I even in the tunnel? Technically you should be close if you know what you're doing, but you could, one fraction of an inch off, teeny fraction of an inch, and you can be, again, in a tendon, in the carpal tunnel itself. And then you're not really getting that medicine where it needs to be, and you're only stopping inflammation. And many times it's not inflammatory. That's why they cut open carpal tunnels, or carpal tunnel release. They're going to open up the top of that tunnel to relieve some pressure. And if we can put medicine in there to separate all those tissues and have healthier signaling versus just putting in a steroid, then we can see better improvements there. So same thing going into a knee. We use guidance to make sure we're in the knee. Probably one of the most common ones that people have seen somewhere, common treatments would be hyaluronic acid or HA, viscosupplementation, rooster comb injections. Kind of goes by all of those different terms. Most people, like, if you say, have you ever heard those rooster combs? Most of them know that word.
They totally
all the other ones are kind of like, oh yeah, that makes sense now. So this hyaluronic acid viscosupplementation is a viscosupplement. It helps make your synovial fluid more viscous, so more thick, so we have a little bit more, and synovial fluid is a fluid within the joint. So every joint has this kind of a lubrication fluid within it. As we age, that lubrication becomes less dense, less viscous, so it loses its compression factor, so we have less shock absorption, we have less fluidity between those two joint surfaces. So if we're able to improve the health of that with some anti-inflammatory properties, we can see healthier joints in the long run. So a lot of people are like, oh yeah, I've tried those injections and they didn't do anything. One thing is most of them come in a series of shots, so you have to have, usually it's 3. There's a few of them that are single injection. There's a few that are 5 injections. Just learned about a new one that's a 2 injection. Anyway, so if you inject and you miss the joint, and studies out there show that you're probably about 80% accurate with joint injections if you're familiar doing joint injections. So if you're new at doing joint injections, you're probably missing more than that. If you're kind of adept at doing joint injections without guidance, you're probably missing about 20% of the time.
That's pretty high, even in someone who has done a lot of them or thinks they're pretty accurate.
And they would probably disagree with that. and of course that those numbers are kind of they're big numbers put together. But even myself, I mean, I do a ton of injections on a regular basis, and I use guidance for all my injections. One of them is fluoroscopic guidance, and so I can see the joint, I can see where I want to be, I can get my needle into that area that looks right and feels right. I start putting the contrast in, and it feels right. It feels like I have that pressure release, like you're in a joint. And then you take the picture and you just have a cloud of contrast. And it's like, I'm not in the joint. It's like, I thought for sure I was in that joint. And then you just move the needle. Sometimes it's a fraction of an inch, or you just turn the bevel of the needle, and then all of a sudden the contrast flows into the joint. So now if I would have put that medicine, which is a 3-part medicine, or say it's a 1-part and I missed all of it, it's not going to do you any good. It's probably going to cause you irritation around the joint, because now you put all of this stuff outside of the joint that's supposed to be inside the joint. So you probably cause more irritation. You didn't help them at all because you didn't get the medicine in there. Or say it's a 3-part series. If you miss 20% of the time and you're not using guidance, I mean, how many times did you actually get in that joint?
You could be missing quite a few.
Right. And then say you do it regularly, it's like, oh yeah, it worked for a while and then it didn't. It's like, again, who gave the injection? Did they get it in the joint or not? And again, and this can be, so sometimes like, well, yeah, that's probably on a really big knee. It's like, well, sometimes that's true, but sometimes it's a smaller knee. I've had the same thing, because then you have a smaller joint surface. You don't necessarily have a big effusion, which kind of expands that bag. So then you might miss, because you might just be on the outside of it, because your needle has a bevel that's probably a good 1/16 of an inch long, and if only the tip of the bevel is in that joint,
that's a good point.
You're not getting all of the medicine in there, even though it feels like it's going in there. But then you get this thick viscous fluid, and you might miss it. So I mean, these are all the things that I think about and I talk about while I'm doing my injections. Because I miss too. But then I have that guidance to prove that I'm there. Ultrasound. So if you're using fluoroscopy, you're probably, I mean, almost 100% accurate. I mean, it's hard to miss if you're using fluoroscopy and doing it right.
It paints a nice picture.
It does, right? It's very If you're missing, I think you kind of know that you missed, and you kind of did it anyway. Which you shouldn't do. I mean, that's not medicine because that could be causing harm. When we are doing ultrasound guided, that probably brings up the accuracy to like 95%, because there's a chance that you could get some of that medicine not going in there, but you can again usually see that on an ultrasound. If you're adept at reading an ultrasound and getting that medicine in there, you can see if the medicine is going into the joint or if it's going into soft tissues. But you need to be good at following your needle. You need to see where the needle point is. You need to make sure that you have all of these things in line too, which is a higher level skill to be able to follow an ultrasound and make sure that you're putting the medicine where you want. So that's where guidance can really come into play. And there's certain things that you need guidance. If you're doing spinal injections, say we're doing facet injections, medial branch blocks, epidurals, you need that the fluoroscopic guidance to prove to the insurance company that you're doing that treatment. Technically, some things we can do ultrasound guided and be very confident, like a caudal epidural, you can be very confident that you're in that caudal space, but the insurance company wants to see the x-ray to prove that you're in that space. So some things we need it, but almost everything we do it because it just adds our efficiency. Again, patient comfort, patient confidence.
I honestly think patients feel a lot more comfortable with it. They're like, oh, you can actually see it. You're not just guessing, because anatomy is so different. So you're thinking, like you said, a small knee should be pretty easy to find landmarks, but sometimes the joint capsule feels a little bit different, or it's not where you would expect it. So I do think it helps with patient comfort and outcomes. It has to help with those.
Right. And I think, again, 100%. I mean, the HA injections, we do those, or the viscosupplementation. Yeah. Most people that have knee arthritis that come here, we do those. I mean, I don't have like hard fast numbers, but easily, 70-80% of our patients that do those viscosupplementations see improvements. And it's not necessarily going to be 100%, like my knees feel great, I have no problems, but at least 50% or more improvement from that viscosupplementation, compared to most places are like, well, we're not going to do that. It's not even going to make you feel better.
Sure. So yeah, it does seem like those series do help, and I think 6 months you can repeat that series, right?
Yeah, almost all insurances. Yeah. There's a few that are different. So they on average they say 4 to 8 months.
Sure. Okay.
But insurance company will cover it every 6 months. There's a few of them out there that won't do it for at least a year, which I don't really get either.
Yeah.
and it's fairly expensive, and it's kind of funny when you look at the whole breakdown of the insurance world and what they're willing to pay for and not. They're willing to pay for this super expensive knee replacement surgery, but there's a lot of studies out there that show that, at least, and I can't remember what the exact numbers are, but I want to say that 15% of them could have been avoided if they would have just managed the nerve pain around the joint.
Wow.
Without even looking at the joint health itself. And then I don't know what the actual number is how many of those surgeries, and I want to say it's somewhere around 40% could have been managed non-surgically. And again, so we're not, by doing something like PRP, stem cell surgery, we're not taking arthritis away. We are not recorrecting that bone. We are not like cutting things off and putting new things in there. We can see some kind of filling in gaps of cartilage breakdown, so we can have a little bit smoother kind of joint surface rubbing against itself. We can see improvements of the structure surrounding the joint, again, making the whole thing healthier, increasing the actual kind of the bioavailability of substances within the joint, so it just functions healthier. And that with PRP, we can see, I mean, there's a lot of studies that show up to 76% increase in functionality. So if you think about doing a PRP and 76% of them are getting better, and again, this might not be 100%, but if we're 76% better than we were, or 76% of us think that we're better than we were before that procedure, I mean, that's huge.
That is, because even, I mean, knee replacements, they're not 100%. I see a lot of people, they'll come in, oh, I had this replaced, but I still have a lot of pain.
And then you think about the healing component of that. I mean, most of the patients that they'll be like, yeah, within a year, you'll probably be back to normal. And this is usually within about 6 months. We're already seeing over 70% improvement by about 3 to 4, probably 6 months, we'll say. 3 months, we're probably about 50% improvement. 6 months, probably about 70% improvement. And again, we're seeing those improvements, and it's something that will probably have to be repeated again, because we're going to continue to break down. I always give the analogy, it's like putting new tires on a car, that you're going to wear down those tires and then you need to put on a new set again. Kind of depends on what's your alignment look like, how hard are you riding it. I mean, all of those things add into how long until you need to redo it. And then genetics, I mean, that plays a piece too, and how well your body repairs, how much you break down, how much are they talking to someone else about their inflammation and controlling that. If we have inflammation controlled, we have healthy diet, we're exercising, we're doing all these things, we can see more improvement. We can see longer lasting improvements.
Do you see that? Like, do you see people who are inflammation's controlled, they don't have diabetes, they have better outcomes compared to people who aren't managing those things? And it's one of those things where it's hard, because it's not that if you have those things that you're not going to be a good candidate. For sure.
But if we have everything as in line as we can, we're going to see better outcomes. And that's one of the things when you look at what we do here at Rejuve, that's part of the process. We want patients to have a healthy lifestyle. We want them to be eating well. We want them to be controlling inflammation, having good hormone control. And if we have all of those things, going to physical therapy, going to the gym, we can pull all these together and we see even better outcomes. We're usually at the top. If we look at those numbers, we're sitting around the top of performers, of people doing things like prolotherapy. Part of that is guidance and our approach to doing PRPs and treatments like that, and the skill of the providers. But some of that is just because of everything else around it making it better.
Okay. So I know we talked a lot about knees, but the injections that you can do, I mean, you can really hit on a lot of different areas of pain, even if it's not a joint. I have a lot of my patients who see you guys for migraines, and it works really well, whether they're doing the nerve injections or they're doing the Botox injections. So can you talk a little bit about that, like all the different body parts?
So I'll probably put in, so this all kind of falls into the category of nerves. And I had mentioned with, not to go back to knees, but with knees, like a good 15% of them could have been treated if they managed the nerve pain around the joint. So the same, like migraine certainly there's a vascular component to it, but it's obviously nerves that are causing us pain. Every joint in our body has nerves that surround it, and nerves that go to it, and nerves that go away from it. I believe it's called Hawkins' law, that every joint, or the things that are affected in one joint can be affected by those nerves that are innervating that joint. So if we manage nerve pain, we can really help manage the pain within the joint. And this is part of our dextrose treatment that we use. We're going to target the nerve. So a lot of times we'll talk about nerve injections, but they're not nerve blocks. So most of the time, I mean, there's a certain number where we will do an actual block of the nerve. Most of these injections are kind of, we call them perineural injections. So they're around the nerve and not like in the nerve, on the nerve. So if we get close to the nerve, and they'll even tell people, if we just kind of like you water a plant, you don't have to have the water on every single root. You just put the water into the area and it will kind of disperse, and the body will, or the plant roots, will pull it where it needs to, but the body and these little nerves and vessels will do the same thing if we get the medicine in the vicinity of the nerves that we're treating. So if we can improve the health, improve the kind of the nerve conduction of that focused area, that is actually going to have an extrapolating effect of decreasing inflammation of those tissues around, because an irritated nerve, and they'll say a nerve can be irritated with a dime's weight of pressure. So if we think, that tiny amount of pressure can cause a nerve to start sending poor signals. Sometimes it's pain, sometimes it's just leaking out these substances that cause breakdown of the tissue around them. Because that tissue, the substances, substance P and CGRP, they're meant to be there as a signal to heal. But if there's just this chronic kind of festering, smoldering, like we talked about last week, release of these chemicals is going to cause that breakdown, and it's going to irritate those systems. So if we can turn down that volume of irritation, we can increase the structure around it as well, or the integrity of the structure around it. So we have healthier working cells, and that can improve overall outcomes. And that's another reason why we perform really well with PRPs, because we're treating nerve pain around the joint or around the area, as well as the actual structures of the joint itself. So when we think about things like migraines, so often people get the posterior scalp there, the back of their head is where these migraines come from. It's from neck pain, kind of tension, headachy things that kind of they kind of trip the wire of migraine. And not always. A migraine, that's a whole huge concept as well. But again, you're working with those patients in the inflammatory world, and then we work with them kind of in that nervous and pain world. And if we're able to decrease that nerve irritation and would decrease tension of those muscles in the neck, we can help relieve some of that pressure. So then if we have inflammation under control and we have these nerves functioning better, we can see a decrease in migraines. And again, I never want to advertise that we will take away your migraines.
Right.
We can, or we can decrease their frequency or decrease their intensity. And I say that's what you hear most of the time, is that things are getting better, that they're not gone, but they're better. And treating nerves. So jumping back on the knee quickly, there's a set of nerves called the genicular nerves that we can target, and these are ultrasound guided. They're the knee nerves. So GEN-U is Latin for knee. They're the nerves that go into the knee. And if we can treat those nerves, we can see a lot of knee pain improvement, again, versus just putting a steroid into the joint. So we're putting dextrose into the joint, making the joint healthier. We are treating the nerve pain on the outside of the joint, making that healthier, and then everything else functions better. Same for feet. That's probably peripheral neuropathy. How many patients suffer from that, whether it be diabetic in cause or vascular in cause? There's a ton of different reasons why they're going to have this kind of peripheral kind of extremity pain. And again, not that we can and will make or I suppose we can, but will we make it go away? Maybe. It's another option out there. I know my last job, there was a guy who's like, if you ever find a cure for peripheral neuropathy, let me know. It's like, so we don't have a cure, but we have all of these things that we can do. I had a guy recently treating who came in and he had pain. I want to say it was somewhere around 10 years. I feel like it was a little bit more than 10 years. It could have been a little bit less, doesn't necessarily matter. But he was told by multiple people that his pain is going to be there. He has some arthritis in the feet, and he has diabetes. So these are going to be his symptoms. Kind of figure out how to live with it, more or less. I saw him, we started doing some nerve injections around the feet. I did some tendon injections because there's a ton of things going on around the feet.
Right.
We have joints, we have nerves, we have tendons, we have ligaments, we have all these different support things, and they take on the load of the entire body. And they're far away from the heart and the nervous system. So we have all of these, it's like the crux of where you probably have a lot of issues. Anyway, we were able to, he was not sleeping because of his pain. He was numb in the feet. He's a drummer, and so that was one of his passions, but he wasn't able to drum as well or as long because of this pain. The last time I saw him, and this was probably 2-3 months of seeing him, and he's like, my pain is basically gone. He has a few little nerve symptoms here and there. He saw his regular doctor, and he's like, my foot pain is better. And he's like, what?
Where do I send
people?
Right.
And that's what, and he did, and he found out where he went, and he was gonna say, you know what, I have these other patients, we're gonna send them to see you, to do something. And again, it's usually not just one thing or the other. So we don't just do a joint injection. We don't just do a nerve injection or just do one injection. Again, we look at this thing and there's a ton going on. So we don't just focus on one piece. We try to get that whole thing feeling better and functioning better.
That's, chemically the body is so complex, but also structurally.
Right.
So you put the two of those together, and there's so much that you can do. So I think once you're combining it can make some life-changing things happen.
Right.
So I want to touch on, because we talked a lot last week about inflammation and how inflammatory sugar is. So can you talk a little bit about the difference between if somebody eats dietary sugar, which is of course always inflammatory, but then you're injecting dextrose, sugar water. Talk a little bit about that.
Gosh, and it's one of those things that it's almost difficult because I can't tell you exactly how and where. I think part of it is the actual gut absorption of the sugar. Part of it is the fact that, so we're injecting sugar, but when we're doing these calming injections, we have a very low concentration of sugar. So we're looking at 5% dextrose. And I'll usually tell people, if I do all of these injections, it's way less than if you were to suck on a hard candy. So we don't have that much sugar that we're putting in.
Okay.
But part of it is that it's already going kind of directly to the cells and the areas around the cells. So then that is going to be absorbed differently in those cells compared to the sugars that are going to go there when they're absorbed throughout the body. And again, the body needs some type of energy, whether it comes from sugar or sugars, I suppose. Glucose is how it has to get there. The body just has to turn it into glucose.
Like more of a complex carbohydrate opposed to a piece of bread or pasta.
Right.
Like
and again, and we talked last week about how the gut is so crucial in that inflammatory component. So I mean, the ingestion of the sugars is where the inflammation happens, I think, within the gut system itself, compared to putting it in these peripheral areas where we can kind of focus what it's doing. But now if we jump that up to a high concentration of sugars, we're actually causing irritation and we're causing inflammation. So I mean, that's probably where you can see it's probably that threshold of how much sugar you're putting in there. So now we go to a higher concentration of sugar and it's actually causing things to flare up a little bit. So that's prolotherapy. We had talked about that just briefly. Now you're injecting this high concentration of sugar to the points where ligaments attach to joints within the joints themselves, and we cause this level of inflammation that the body now responds to. So we talked last week about the body getting stuck in chronic inflammation, where it's just kind of smoldering and hovering and kind of ignoring what's going on, and not having open cell transport chains to be able to cause that healing. Now we are inducing a new acute inflammatory reaction that the body can respond to. Again, different when we're using high concentration compared to low concentration, and have that conversation frequently, because we talk about the sugar injections and then these other sugar injections and then these blood injections,
but then don't eat sugar, so it can be a little confusing.
And then in diabetics, I mean, they're frequently asking, so I have diabetes, how is this going to impact me? And it's going to be way less than a typical steroid injections, because the steroids, the corticosteroids, will actually impact your body's ability to process those sugars within the liver. So now if we do this very low dose steroid injection with dextrose, we are going to impact your sugars significantly less than one cortisone injection from kind of a standard clinic.
Yeah, I have quite a few patients who they have diabetes and they've come from doing a cortisone injection at a regular clinic, and it really does affect their blood sugar. So you're not seeing that effect with
So very, very minimally. Of course, some people that have a very sensitive system, because some of our injections we have a nano amount. So we're putting in, so most places are using, so Kenalog is the most common. They're using about 40 milligrams. We're using 4 milligrams. So we're using a tenth of what they use. So if they do, I mean, their one injection, I mean, it takes us 10 to get up to that level of cortisone within the body. So even if and sometimes we'll do frequent injections. I mean, commonly see people every 4 to 6 weeks to manage pain. So I mean, that's one of those things where we talk about pain management compared to pain cure. So we're going to do as many things as we can to try to help them feel better, function better. Part of it is that the insurance company still hasn't gotten on board with doing PRPs and regenerative medicine, so that is an out-of-pocket cost. Many people can't afford that, especially when we're getting older, we're on Social Security, limited income. You can't necessarily put that money into it because we have healthcare, and healthcare is so expensive anyway with everything else. So we're going to do the things that we can do insurance covered. So I may do these kind of low-dose steroid, dextrose injections sometimes once a month, sometimes every 6 weeks to manage that pain. And those people are able to continue to function and do the things that they need to do and feel better around their bodies, which is obviously important, because then we can help decrease inflammation if we can keep them moving and keep them doing things, keep them a little bit happier, keep them sleeping. So pain management. So we look at multiple ways we can pain manage, and we have the dextrose nerve injections that's going to help decrease nerve pain around joints, migraines, other body aches, back pain, huge for back pain. Before coming
and we
here,
didn't even get into back pain.
I know.
So many people experience back pain.
And I would say in back pain, so I talked about, so knees are one of the most common kind of arthritic things, but I mean the back, a lot of times arthritic too, but back pain, I mean, that's probably at least half of my patients are somewhere in the back pain, whether it be kind of high back, neck, low back. Previous to coming here, I mean, back pain was one of those things like, there's not much I can do. I mean, there's muscle relaxants, they can help a little bit. We can do steroids if you're really flared up, that might help you for a little bit. You don't really want to do surgery because that's kind of a mixed bag of what's going to come out on the other end. And physical therapy, but most people are like, I've done physical therapy, I don't want to do that. Or it doesn't cause that immediate change. So by doing these perineural injections, I see back pain reduced significantly in so many people. And then we can do the non-steroid epidurals, which again just kind of help calm all of that tissue down, helps with radicular pain, helps with herniated disc, kind of that pressure on the nerves, helps decrease some of that, and people are functioning better so they can do more therapy, so they can maintain their improvements. And then if we've done all of those things and maybe we've gotten them to a point where they're like, you know what, I feel pretty good, but I still have this breakdown. I still have this stuff that's going on and I want to improve that. And that's when we pull them into PRP if they can afford to do that out of pocket. And it's not crazy expensive. I mean, this is one of those things when I talk, so I use car analogies pretty frequently. I mean, how many people have a vehicle that they spend, I mean, car payments. I mean, you could spend anywhere from, I don't know, $500 or maybe a little bit less, but we'll say $500 to $1,000 on a new car every month. This procedure, say a back PRP around here is probably 2 to 3 car payments, depending on what your car payment is.
So I mean, it's an investment, but it's reasonable.
Right, and it's an investment into your body.
Yes, the one body that you get.
Right. And when you're in it all the time, it's like, I have this fancy car that I drive to work. Or I drive
to
home.
Be in my body
it just needs
the whole
to
time.
has to get me to and fro, but it does nothing else for me, really. And you want it to be dependable, yes, but we want our body to be dependable too, because again, we're going to be with that forever. We're not going to continue to trade up to a different body.
Can you imagine if you had the same car for like 100 years? That you could
and what would you
be
do?
In your body?
Would you maintain it?
Exactly. You would hope so.
Right. Yeah. And things like oil, like you change the oil because you know if you don't change the oil, something big bad is going to happen. You can let that oil get really old, and it'll still function for a while until one day it stops.
Yeah, that's such a good point.
And then everything is broken down, and then to get that fixed is huge. So if we are constantly maintaining, we're putting in good fuel, we're changing the oil regularly, we're maintaining things, we're making sure that they're working well, that can make this body last way longer. And that's kind of what PRP is getting that extra bit. It's giving a little bit more maintenance. It's kind of resurfacing your rotors so you're able to stop more in the future. I mean, all these car analogies that we can think about the body, and if we put that investment into our body, the only one that we have, and you might only have to do that every few years. I mean, how often do you see this major repair for your vehicle? And yet it's never fun. And it's like, I don't want to do that. And of course that gets in the way of needing to take care of our bodies too, because we have these other expenses that are going on. And we look at our insurance world right now and how we have these huge out-of-pocket costs. So I could ring up your out-of-pocket cost pretty quickly, and you can reach your out-of-pocket deductible or maximum. But if we would have maybe looked at doing that PRP sooner, you might prevent reaching that maximum for some years. Again, depending on who you are and what you're dealing with. But I mean, again, how you manage that money and the body. So again, they're an expense and it's an investment into your body and into life. But you can make yourself feel way better and function better and be happier and sleep better and eat better and exercise more and be there for your family and doing all of these things if we have some of this under control. And so many people look at it and they're like, I'm just not ready for it yet. And that's not a judgment, because I'd even fall into the same boat. I've been saying probably for the last 6 months, like I should do another Prolo or a PRP to my back, because
we're the worst patients.
I know, because I can feel that those things are there, but life is busy and that it takes time and it takes money. And I know I should do it and I plan to do it. But I also am doing a lot of these other things to help manage it in between time. And I'm very conscious of it. I'm not just going back and causing the same breakdowns that I have before. Anyway, so.
Yeah, and I think controlling pain is so important, because pain, it's not just pain, right? Like, it's a physical stressor on the body, which causes gut breakdown, hormonal imbalance, inflammation. Like, it's so much more than just pain. Oh, my back just hurts, I'm just dealing with it. It's like, no, it's causing all of these. It's causing you to age more quickly because it's so stressful on your body. I always tell people the body really doesn't know the difference between physical or emotional, mental stress. So you having a super stressful day at work, we're aware of how bad that is for us, but then also having this physical stressor constantly inundating us, it's just fatiguing our adrenals, causing so many issues. So it is important to deal with pain.
And then it just snowballs. So then you have all these things causing that breakdown, that adrenal fatigue and inflammation within the body, and then we see more joint breakdown, and we have more pain. And to kind of try to cycle that back up, and again, it's a battle, and we work with it, but that's kind of what we have.
So when people, I just have some knee pain, I'm like, no, it's not just knee pain. It's so much more than just knee pain or back pain. So definitely important to see, someone who can help them address that,
and
whether
to manage it before it becomes really bad pain. Again, because we let it go too far and too much, and then it is harder to manage, and it takes more investment of time, effort, money to be able to fix that, or to, again, maintain it and get it back to a better operational standard.
Yeah, absolutely.
Okay. What else? I think one of the other pieces that we want to talk about a little bit, so we talked a lot of the things that we do here, some of the things that, and I mean even more that we're doing and kind of in the more immediate future of doing. One of them is ozone therapy. So in ozone, we could probably have a whole conversation on ozone in the future, but this can be something where we can inject it into joints. and it's working on these different pathways within the joint and within the body, when we're using it within the body, to calm down the inflammatory process. So again, inflammation is a thing that causes anger, and again, we've talked about corticosteroids breaking down inflammation, but we don't want to just turn it off. We want to quiet it. And if we can quiet inflammation and not turn it down, we can see better outcomes. We can see more pain relief. We can see better functioning within the cells. Then the other theory with ozone is that we have these kind of viral infections that we had young in life that start to creep up and cause issues later on in life. There's more studies coming out that there's probably even these low-level infections going on within joints that are causing these breakdowns within the joints. And if we're able to impact that inflammatory reaction, that infectious reaction within the joint, we can see improvements. So a lot of our patients we're getting on doxycycline, which is an antibiotic that, I mean, it treats bacteria, treats inflammation, and that could be one of the reasons why it treats some inflammation, is that it targets the right bacteria that inflammation is going on.
So you're injecting that into the joint?
So it probably could be, most of the time oral. Yeah,
Okay.
a very low dose, kind of a regular, low dose prophylactic, kind of like you were thinking, if someone has it for maybe acne when they were younger, or say like rosacea, something like that. You might be on these low-dose antibiotics to be able to help prevent things. But again, if it can make our whole body's function feel better, less inflammatory, I mean, that's probably going to bolster our immune system better than thinking about the worries of antibiotic stewardship, which is also important. But again, you kind of have pros and cons about them. So that's one thing. But ozone is not the same type. It's not an antibiotic. It's just going to kind of make an unhappy environment for bacteria to live. And that's the other nice thing about our dextrose injections. Sorry, just come back on that. Good. So I've been here 3.5 years, and I have had one, maybe 2 infections total.
Okay. Well, that's pretty low, because you do a lot of injections.
And then sometimes it's like, was it even? I mean, the one guy, I know it was, he had this reaction to a drug that sometimes gets this kind of pseudo-infectious reaction. And it had a very low level of bacteria on there too, but we just talked about it possibly being in the joint anyway. And it's one of those, if you see this reaction, you kind of need to treat with antibiotics. So that was one. That was maybe an infection. And then maybe a few like kind of just very soft tissue-ish. But dextrose is actually helps prevent the growth of bacteria, and even is a little bit bactericidal, so it will actually kill bacteria a bit. So all of our joint injection is going regularly. Again, very low risk of getting an infection in there.
And you guys are, doing how many injections a day, do you think? I know. Just to put it in perspective, like 1 to 2 in 3.5 years is probably like 0.01%.
Yeah, I mean, and I am, on a regular day, say like on Fridays when I do knee joint injections, I mean, I'm 30-ish joints that I'm injecting.
So super low likelihood of infection.
Right. And if I'm doing like back injections, like or our nerve injections, I mean, many of those patients, and they like to brag about it when they go to their friends, like, I had like 50 injections. It's like, you did. Like, that's not even an exaggeration.
True.
I am injecting the body probably a good 50 times for most, like a low back or a knee pain, something like that. So it's a lot of, but these are like little itty bitty needles, similar in a way to acupuncture needles. So low trauma, low bleeding, again, low risk of infection. Not uncommon that you get some irritation around it, but I'd say also pretty uncommon. I don't see a lot of people with irritation after their injections, and very well tolerated. Every now and then you get pain, but most of the time I say it's somewhere probably between a mosquito bite and a fly bite. Like, you can feel them, and some of them are annoying, some of them make you jump a little bit, but when it's over, you really feel pretty good.
Awesome.
And you'll see like immediate results in a good, again, 70 to 80% of people. They will leave here feeling better than they came in with those type of injections.
So there's not always the downtime of like when we were talking PRP.
Right. So, and that's part of what we do here too, is that we're managing that pain even around a PRP. So some people, that's one reason, like if you look at big studies about PRP, they talk about pain around injection, and not just the pain of the injection itself, the pain after the injection. And a lot of times that's this nerve pain that just kind of gets fired up and doesn't get managed. So a lot of patients, we will manage that pain going into PRP, so we get kind of that smoldering, irritating pain away. After PRP, we're also able to be there to inject to calm down the pain. So when pain is their bigger limiting issue, we can actually manage that in the process too, without putting steroids in there, which then decreases its ability to heal. So we're working with them on both sides to help manage that pain, and again, see positive results in the long run.
Wow, that's great.
Yeah. A few other things that are kind of coming down the pipeline. Tissue modulation, so actually like creating new meniscus or new cartilage within a joint. I think that's quite a ways down the pipeline of things that can be done. but usually that's going to be supplemented by some type of a biologic like PRP or stem cells. Something I should kind of quick touch on too is when we're talking stem cells, we are not talking baby embryonic stem cells. We are talking either bone marrow stem cells, mesenchymal stem cells that are coming from your own body. So these
you guys are always harvesting from that patient's body, and using their own.
Here at Rejuve currently we're just doing bone marrow aspirate when we're doing stem cells. So we're taking that out of the bone marrow. These are these cells that kind of, they're little baby cells. They don't know what they want to be yet, but they're programmed to become kind of anything. So if we inject those into a joint, they can become cartilage tissue. They can become meniscus tissue or ACL tissue. Like if you kind of get the area primed right, it's going to go there and turn into those tissues. Again, it's not going to be all of a sudden you have a 20-year-old knee, but we're going to fill in gaps and breakdowns and help repair that tissue. So yeah, we're not using baby stem cells. These are all coming from your own body. And processed all right here in our lab. Again, how we do it here, everything, like if we're doing blood draws or if we're doing stem cells, kind of it's harvested right here, it's managed within our lab, and then it's given right back to you, usually within the same day. I'd say almost always within the same day.
I think that's nice for patients too, to know everything's staying right here in-house.
Right, yeah. So yeah, it's not sending out to a lab and then you kind of wonder, it's like, did they mix something up or not? And overall, our volume is low enough that usually there's going to be one person that comes in that's processing and getting that injection back into their body. So it's like we don't have multiple things all within the shelf loading at the same time and then going back out. And I'd say most of your regenerative therapy locations are probably going to be like that too. Just kind of the manner of how you kind of sequence treatments, you're probably going to be very confident that you are getting your body product. It is minimally manipulated, and so that makes it safe too when we think about the FDA. So there's a lot of information out there that it's not FDA approved, and that FDA approval is interesting because it's our own body product being placed back into your own body to create changes within your body. Like we're not taking another drug and putting it in there to do something. We're just taking your body product and bringing it in to do it. So that raises a huge question, like why do they say that? And it's minimally processed. I mean, it is spun down at centrifuge. So we are just spinning it down, concentrating those platelets in one spot, pulling it out and putting it back into your body. And I'd say there's one thing we do called a platelet releaseate, which we actually break down the platelets. Usually there's different ways that you can do it, but you kind of just deshell the platelets. So if we kind of think about like a boba, if you want to say, like a boba tea, like those little bubble things. Yeah, so they're like these little platelets that have this something inside of it, that little burst of flavor. So we're getting rid of that burst of flavor, or the shell on the outside to get the flavor so we can actually do things within the body. And then it has all the growth factors, the inflammatory mediators to be able to help us heal.
Wow. I mean, there's just so many options for patients to help them with whatever pain
so
they
cool.
may be having. It is. And we see a lot of the mutual patients, and I would say a good majority of them are always feeling better, which is awesome.
Right. Yeah, and it's always, so there's a difference, I want to say, between better and perfect.
Yes.
Because there's so many people that, like, when they come in and they're broken down and they have pain and there's things going on, like, for me to get you from 0 to 100% happens. But that's not going to be my expectation. I usually expect to take you from like 0, like I'm not functioning, things are really bad. I can take you up to like 75, 85, 90% improvement pretty regularly and have you feeling better on a regular basis. And sometimes that's maintenance from that point, where if we can keep you feeling that much better, and you're still probably going to have some pain because usually when things have broken down, when you've come in and you've had this problem, there's always going to be a little bit of that lingering, and we're human bodies. We're exposed to inflammation things within our system. We're eating foods that are in our system. We are not always making all of the right decisions all of the time. So we just have those issues. All right. So, I mean, we talked a lot about all of our different non-surgical orthopedics kind of pain management things. I mean, there's a lot more out there. So one of the things I would say is if you are having some pain or some dysfunction, or even having a question that like something just doesn't feel quite right, I mean, certainly come in and give us a try, or find someone near you. I mean, when we think about non-surgical orthopedics, a lot of times you usually don't look for orthopedics. So a regenerative orthopedic specialist is probably where you're going to find someone that does treatments similar to us. And of course, they're different kind of everywhere you go. So here we're at Rejuve in Way Park, Minnesota, central Minnesota. I mean, it's a great place to get treatments. There's a lot of things around, and people actually come here from all over to get their treatments as well. We've had NFL players, we've had other kind of major sports people coming here to get their treatments done. So again, a great place to come if you're like, you know what, I heard what they're talking about on Wellness Warriors. I love it. I want to do it. Come here. I mean, it's a great place to visit. Winter is a little colder. Summers are great. To be able to get good treatments to be able to make you feel better in the long run. Now we can treat chronic pain, whether it be coming from nerves, whether it be back pain that you've had for years. I'd say even if you have had it for a very long time, can still try it out because it's usually something that you haven't tried. All the time we hear, I've tried everything. It's like, well, but have you? There's probably something that we have for you that you haven't tried. And there's a select few that we've tried everything, and everything that we have still doesn't work. So then we might send them back to surgery. And surgery is still a good option if we have tried everything. And that's usually what they say. Surgery is the last result or the last option. So let's try these other options for some people. So come, give it a try, see if we can make you feel better. Again, perfect may not happen, but better likely will. It's a great way to get your life back in a way. If we can get pain under control, sleep is better, functioning is better, diet is better, usually exercise is better. And it doesn't even have to be exercise. I know the word exercise kind of brings people down, but just physical activity, being able to being able to move and do things, and just having good physical movement or higher quality physical movement is definitely possible.
Yeah, absolutely.
Right. Well, thanks. We'll catch us next week. We should have another Wellness Warriors. I don't know what our topic is yet, so we'll figure it out. Right. All right. Thanks, everyone.
Please note that the opinions expressed in the Wellness Warriors podcast are those of Shelby, Terrence, and their guests and are meant to be educational and informative. This podcast is not intended to provide any medical advice or replace the guidance of a qualified healthcare professional. If you have specific concerns about your health, we encourage you to schedule an appointment with us by calling us at 320-217-8480 to discuss your individual needs with our team of experts. Remember, always consult with a healthcare professional before making any changes to your lifestyle or treatment plan.